for the final speaker will be the late Marco Ranieri. Marco from Turin is going to talk to us about quantitative unloading and synchrony determined by electrical activity of the diaphragm. Marco.
Okay, thank you very much, and I apologize for being late, but I apologize. Now, I got this title some time ago, and I honestly didn't pay much attention when I got it. I was asked to give this presentation. I said, yes, of course, I will do it. And then, a few weeks ago, when I started to put together the materials for this presentation, I realized how complicated and, I mean, without a clear message to me was the title. Quantitative unloading and synchrony determined by electrical activity of the diaphragm. It sounds like a mental masturbation more than a title of a scientific presentation. So when I don't understand what's going on, I try to identify the key words that may help me to figure out what I have to say and how I have to work on it. So quantitative unloading is clearly something that has to be defined. Synchrony is something that is definitely of clinical relevance for us as a clinician. I don't know for rabbits, but I can tell you that for a clinician, synchrony is a major problem. And something that needs to be defined is electrical activity of the diaphragm. I'm sure the previous speakers fill you up with models on how NAVA works with fancy cartoons, videos, and so on. I don't have it. I have a very simple cartoon. What essentially NAVA does is to measure the electrical activity of the diaphragm, that is the signal that goes from the brain to the muscle, and then use this signal through a complex electronical process, feeds this to ventilator, and the ventilator uses this signal to apply flow, volume, and pressure. So in any assisted mode of mechanical ventilation, we can then try to find the difference and try to identify the major characteristic of NAVA. In pressure ventilation, you target the pressure, and the cycling off between inspiration and expiration is regulated by the flow. In assist-controlled mechanical ventilation, volume assist, the target is the volume, and what regulates the timing is time cycle-off function that you set on the ventilator. With NAVA, what you set is the proportion between the patient effort and the amount of pressure, flow, and volume that the ventilator will deliver. So how much pressure the ventilator will deliver and for how long will be decided by the interaction between the regulating algorithm and the signal measured in terms of electrical activity of the diaphragm. So what NAVA does, it measures the electrical activity of the diaphragm, so finally I got it what it was, and delivers pressure in proportion of the diaphragmatic activity of the diaphragm, so provides a quantitative unloading. So this is what it does. You have pressure, flow, volume, and electrical activity. Big breath, big pressure, big volume. Small effort, small electrical activity, small volume, small flow, small pressure. Let me see if in our, not clinical experience, in our clinical research experience, the quantitative unloading may play a physiological role. This is a study that Gabriela Ferreira presented, I think, a few minutes ago, because I got an SMS saying that this was a very successful presentation. Right, Gabriela? Good. So what she did in her study, she evaluated synchrony and other keywords and diaphragmatic unloading in patients undergoing weaning from mechanical ventilation during pressure support ventilation that is clinically set, during NAVA setting the level of unloading to provide the same pressure as in pressure support, so as during clinical standard ventilation, and setting NAVA 10 centimeters above the clinically set level of pressure support. These are the patients. Talk about 13 patients during the weaning process after an average of 20 days of mechanical ventilation, admission for COPD, multiple trauma, sepsis, ARDS, pneumonia, and all were in the weaning phase as identified by the blood gases, normal pH 7.4, PCO2 45, PF ratio close to 300. So patients ready to be weaned, clinically ventilated with pressure support. The electrical activity of the diaphragm measured during standard pressure support, NAVA, and NAVA set to provide 10 centimeters of water of pressure more than what clinically used, demonstrated that with NAVA, using the driving algorithm of the ventilator, the electrical activity of the diaphragm was significantly lower. Please pay attention to the fact that the level of pressure here and here is identical. So by using a different driving mechanism, the electrical activity of the diaphragm was reduced by NAVA. This translated into an improvement of patient-ventilator interaction. In fact, the wasted inspiratory effort, the missing effort, were dramatically reduced by the use of NAVA, to go back to 10 years ago. The total number of asynchronies was reduced by the use of NAVA. And also, and this is probably the most interesting piece of information of this study, respiratory mechanics improved, as indicated by the significant reduction of intrinsic PEEP that was observed when the patient was shifted to NAVA. What did not fit in this is the fact that inspiratory muscle effort, indexes of oxygen consumption of the respiratory muscle, although tended to be lower during NAVA, were actually essentially the same. And the only significant reduction of inspiratory muscle effort was observed when NAVA was set 10 centimeters of water pressure higher than the pressure clinically used during pressure support, suggesting that what it counts in terms of inspiratory muscle effort is the level of pressure that you apply. On the other hand, what it counts in terms of patient-ventilator interaction is how the ventilator is able to feel the patient needs as expressed as by electrical activity of the diaphragm. So the electrical activity of the diaphragm can be used as a single piece of information. Is this single piece of information of any clinical use? And this is the second study that Gabriela will present in this conference. We screen every day patients during the weaning phase. They went spontaneous breathing trial of 1 hour, and then if successful, they went to spontaneous breathing for 48 hours. And she measured and she identified the weaning failure in the different phase of the weaning process. And here you have an almost objective definition of what the weaning failure is. And during this entire process, Gabriela measured the electrical activity of the diaphragm using the catheter. Here you have again the patients. These are 12 patients coming from different diseases, COPD again, ARDS, pneumonia, multiple trauma. Some of these patients were the ones studied in the previous study. Ventilated for 26 plus or minus 10 days, all in the weaning phase as indicated by the blood gases shown here. The ability to predict weaning failure was compared to the standard, the gold standard, that is respiratory rate, tidal volume ratio as originally proposed by Martin Tobin. And as you can see, in this series of patients, there is not clear cut between success and failure. There is a signal, but it's not clear. It's not as clear as the measurement of the electrical activity of the diaphragm as expressed in relative terms to the maximum activity of the diaphragm measured during a spontaneous maneuver and deep breath. Here you can see that the EDI max was able to predict weaning failure better than the gold standard. Now, this is a preliminary data analysis. Receiving operating characteristics curves should be obtained, but I think there is an interesting signal. So NAVA and quantitative unloading. In our clinical experience, based on these data, we can say that electrical activity of the diaphragm, respiratory muscle output coupling is improved in a sense that for the same pressure developed by the respiratory muscle, the firing rate in terms of electrical activity is reduced. If this is good or bad in physiological terms, in clinical terms, I have no idea. What is certainly improved is the patient-ventilator interaction. But also here, I would tend to say that a better patient-ventilator interaction is something good for the patient. We still don't have strong clinical evidence supporting the concept that the optimal patient-ventilator interaction turns into a better patient outcome. For what it regards the electrical activity of the diaphragm, it looks like it is possible to use the physiological information in terms of EDI and EDI max to identify patients that can be weaned or cannot be weaned off the ventilator. So the measurement of the electrical activity of the diaphragm is not a valuable measurement that can be used to run the ventilator, but by itself, it may be a good monitoring tool in the hands of the clinician. We still need the formal demonstration that all this translates into a clinical benefit. Thank you very much.
Thank you very much, Marco. This is now open for questions. Marco, maybe I'll start. Your last statement was, of course, an interesting one, and that is waiting for the formal justification for where this is used. What patient groups do you think NAVA would be most likely to be of greatest clinical benefit in terms of clinical outcomes?
I think what it would be worthwhile to invest $10 million for a large clinical trial. In other words, I would invest it in patients where I have a formal measurement, assessment of the functioning of the neuroventilatory coupling. In other words, patients where I know that the contraction of the respiratory muscle is coupled to an increase or an decrease in terms of ventilatory output. I would not include patients with sepsis, high minute ventilation despite respiratory high pH, respiratory alkalosis, because in these patients it's very possible that the neuroventilatory coupling is impaired. So I would look at patients with weaning, because if they are able to sustain, to pass a first weaning test, means that there is space where we can say that physiologically neuroventilatory coupling is preserved.
Martin?
By the way. Tobin, Chicago. Marco, very nice presentation, and I saw Gabriella's poster, very impressive. But you have to be very careful when you compare weaning predictors to ensure you don't have test referral bias.
Absolutely. In fact, I was very careful when I said this is a very preliminary analysis, because only the receiving operating characteristics, they should be evaluated also in terms of power, because I'm not sure that those measurements, these are repeated measurements in the same subject, may provide a sufficient power. In fact, we didn't show any receiving operating characteristic curve.
But ROC curves won't overcome test referral bias.
So what is the test we should be using?
You have to, you can't correct for it.
Okay, so we can, okay, I'll send you the manuscript for evaluation before I submit it.
Marco, can I go back to your previous answer about neuroventilatory coupling? You said, I'm not sure exactly what you meant by that. You know, when you said, I mean, there's neuroventilatory coupling. You've got a signal coming down, muscles turned on, and you get ventilation. So
let me say, if you run the marathon, the signal will be strong, ventilatory output will be large. If you sleep, respiratory signal, electrical activity of the diaphragm, pressure developed by the diaphragm will be small, ventilatory output will be small. This is the neuroventilatory coupling. Now, if you get sick, you get the same relationship, but with a different slope, right? Now, if you take a patient with sepsis, he will generate high inspiratory effort. He will generate high minute ventilation, regardless of the pH. That is a case where I would not use NAVA, where I would not use pressure support. That is a case where I would use sedation, eventually respiratory muscle paralysis, and assist control mechanical ventilation.
So how would you measure that at the bedside? I mean, so you see a patient tomorrow, forget this disease state.
Yeah, well, that's, I think the electrical activity of the diaphragm can be a good monitoring tool to identify this kind of patients, for example. That's why I think that together with the new mode of mechanical ventilation, the measurement of the electrical activity of the diaphragm may be a potential good thing. And I have to say that I changed my mind, because at the beginning I was a little bit skeptical about the use of the EDI signal as any useful tool for monitoring. But now, probably it's more interesting than now itself, in a way. So EDI may be a good way to measure it. The other thing are clinical condition. I mean, we know that the patients with ARDS or a patient with sepsis will not tolerate any mode of partial ventilatory support because of the impairment of the neuroventilatory coupling. John
Any questions?
Agrees.
Krister?
I think, if I understand what you're saying, it's like what we always do in this case is that the first test we do on a patient or an animal, just to see that they respond, is we simply take them down on assist and see the drive go up. And then we put the assist back and we see the drive go down. Then I think the rest of it is a decision on saying, are you happy with what you see or not? Are you happy with the tidal volumes, the blood gases, the respiratory rate, the pH, anything? But if I understand what you're saying is that, because the practical part that Art is talking about, I think that's what, if you're in pressure support, if you're in anything, you see the asynchrony. If you get the synchrony, you see it. But the thing is that if you increase the assist, if you use a mode that hyperventilates them, they go down because they become hyperventilated, finally apneic. But you can see the drive responding, and that means that the receptors are there. And I don't think what we have seen so far is patients with sepsis and so on doesn't necessarily not respond. Some do not respond, but some do. And I think that's the test to do, is just to see that the neural feedback is actually there. And when you start to assist, which alters the neuromechanical or neuroventilatory coupling, then you are improving the neuroventilatory coupling, the patient feels more relaxed, and therefore, hopefully...
It's possible.
Yeah.
But you said, as we do in the States, you're in Canada?
No. No. Well, yes, we do. It's like I said, I talk more for St. Michael's than anything, but there's no standard for that. But I'm saying, like, if we see a patient that is not, or any situation where you do not see a reduction in drive, then we are very cautious.
I agree.
Yeah.